Well, first of all, I obviously want to thank you very much for inviting me here today. I'm based out of the Houston area, so I got to fly from Houston up to here last night and got to visit a little bit of rain. We haven't had rain in Houston for like 8 months, so it's kind of nice to see a little bit of this stuff going on here, so it's a little different on the weather side. As they mentioned, I've been in healthcare for a long time. Think of me, though, as I am really the strategic business philosopher around healthcare IT. I was not the chief technology officer at any hospital, but I was part of the executive team. 129 hospitals I worked in over time, which basically means I can't keep a job. But the reality was I'm a turnaround specialist. I was brought into organizations that had problems with their technology, and really, how are we going to expand our business, and can technology help us get there? So I never really pushed technology as a solution ever. It was all about, here's our business issues, here's where we need to go in our healthcare organizations, and can technology help us get there? Because one thing I saw in healthcare over my 37, 38 plus years is a lot of people sell technology that does not solve our business problems. And the big problem we have in healthcare is that most people in healthcare don't know what questions we have to ask. We have an idea, we want to expand our business, but we don't know what right questions to ask to get to the right technology. So that's where my whole approach was, how to bring the technology people together with the hospitals and physician offices and healthcare plans, and a little on the pharmaceutical side, but basically bringing everything together. Now obviously with business intelligence tools, there's a lot of things we're thinking about. This is a big, exciting time, especially the next 5 to 10 years when we're going to have a lot of potential for this. But it's also an area that's very scary for a lot of people, because we have a lot of data but not a lot of information. And I'll be talking today about where we are in the industry and what the challenges we have. But we're overwhelmed with data, but we don't have a lot of information. What I need is knowledge. Don't give me 10,000 pieces of data. Give me what I need to know right now to practice medicine better. And that's hard to get. We've got a lot of data, but not everything else. So again, we're obviously very much data rich, but really information poor. And we really need to find a way of bringing everything together to get precise decision making at what we call the point of care. When the doctor's in front of the patient, what do I need to find out to help treat this patient better? What are the best protocols? And obviously to do that, we have to involve physicians and clinicians. Too much time today, we've got technologists talking to technologists. Our technologists talking maybe to the CFO or the CEO of a hospital or a healthcare plan. We got to talk to the doctors, because those are the real end users of a lot of this technology. Now obviously in the healthcare plan side, we're talking to people who are managing the cost of healthcare. But still, it has to be affected by the decision makers. In a lot of cases, that is the physician, overwhelming in most cases. And obviously the goal of business intelligence is going to be to improve quality of care, but also cost savings. How can I get information that's going to help me reduce the cost of healthcare? We are by far the most expensive nation when it comes to healthcare. Twice as expensive for healthcare than any other country. But we rank, I think last thing I saw, we rank 17th in healthcare overall, right above El Salvador. So a lot of other countries are doing a much better job than we are doing in the health of patients. But I guarantee you, if you get shot and get in a car accident, I want to be in the United States. Because we're great at taking care of critical issues, but we're really bad at taking care of health. How to keep people healthy out there today. The genesis of all of this, though, is we're buried in paperwork in the healthcare industry. We got paper all over the place. And that's one of our challenges. We're really behind the rest of the industry because we're so paper-based. And we're trying to move all of that to obviously technology. To get, like on the corner up in here, the MRIs and CAT scans, where I can actually see inside of the brain and everything. And we can cut the brain into little pieces and look at where the issues are. We got to move all that paper to some kind of technology so we have it at the point of care. But where are we today in the healthcare market? This is where everybody really thinks of this. We're in the horse and buggy age. We are at least 10 to 15 years behind any other industry. And why is that? When I started going into getting my education and getting into healthcare administration, we required one computer class. Physician offices, doctors that come out of medical school have 1 or 2 computer classes in the past. Now every doctor that goes through medical school is using computers. So we're moving the industry, but very slow today. We're way behind everybody else in this industry. And one of the challenges we have is, where is most of healthcare going on? I came from the hospital side. 25 years of working actually inside hospitals. We thought we were the center of all information. And a lot of the big universities think they're the center of all of it. But most of healthcare is delivered in the physician's office. You've got inpatient setting, about 12% of all the visits go to the hospital, but over 80% of all your encounters you have is with your doctor in their private office. So again, it's not everything's in the hospital, it's the doctor's office. And that's probably the part that's less automated than anything else, is getting the doctors away from paper charts to electronic so that business intelligence can actually work. But where's the data? So obviously when you go to a hospital setting, we got a lot of data about you. You go to a doctor's office, we're finding out pieces of information. So you start looking at where the actual data is. So the first screen was the number of encounters you have, and this is where the data is actually located. We have to find a way of bringing all this data together in one common data warehouse where the business intelligence can look at all of this. That's what we got to have. That's what we're looking for. And for the last 30 years, technology companies have been coming to us saying, we can solve your problem. We can bring all this data together. We have the technology to do this. The challenge is, we don't have the data in a structured form to put it into these warehouses. It's mostly paper-based today. So again, we're moving towards electronic, but we've got the challenge there. So you start looking at really where we have been over the time, and although the colors don't necessarily show, the bigger graph is paper. So in 2000, we were almost all paper-based. And now we're moving along. And by 2015, we're probably going to have half paper and half electronic. Go to banking. What percentage of all their stuff is still paper-based? Well, I know when I go to my bank, and actually I don't go to the bank, Carl, I do everything online. So I don't get statements anymore online, although sometimes they still send them to me. But everything's electronic today. We don't deal with paper as much. Why in the healthcare system are we still paper-based? There are technologies that can help us get away from the paper, but it's been very hard to get the older physicians, the older hospitals, especially when you've got a patient who's been coming to the hospital, say, for 10 or 15 years, and has 4 volumes of charts this big. All this is paper. How do I take 500 pieces of paper and get that into data? Very hard to backload that kind of information in. And there's new technologies that are out there, natural language processing technology, where I can look at a dictated report, an operative report, and pull data out of those things. So we're getting there, but we still have a challenge because we're so paper intensive today. There's a term you may hear about, electronic health record, EHRs. The government's putting a lot of money into this. Realistically, over $26 billion in the next 5 years on helping us move towards electronic health record. So you'll see EHR, sometimes you'll see EMR, electronic medical records. Think of the electronic medical records as you go to the hospital and they capture all your medical information. Electronic health record is all your medical information and all your health. How do you feel? What's going on? Your health of your organ, of your individual, not just your medical condition. So you'll see a lot of initials. We use a lot of initials in healthcare. One thing I found though, after my 38 years in healthcare, it's always 3 initials. It's always EHR, practice management is the PMS, HIEs for health information exchange. It's amazing we always use 3 initials. I don't know if IBM started that, but 3 initials. Now, in the 80s, we had CHINs, CHINs, and we had RIOs in the 2000s. Everything those 4 initials didn't work. It's one of those funny things in healthcare. It's got to be 3 initials. So I think IBM started it, so we kind of follow that. So if you see a lot of initials, it's usually only 3, and we use it a lot. When it comes to the physician offices, these are the doctors you see in their offices. We have it, oops, see sensitive. There's a trend. What percentage of the doctors are actually using technology today? And what you have is the blue line, which is really the percentage of doctors in the United States that have bought an electronic medical record system. So they've gone out and spent money on buying a technology that brings all the data together, and they can put everything into the computer, which is really great. The green line is the percentage of the doctors that are really kind of using it basically. I may use it for a little bit, I may be using it for document imaging, or maybe writing a prescription for medication that goes to your pharmacy. And the red line is how many doctors are actually using the product. Full application. The problem is we've got, in 2010, about 10% of the doctors are using products, but 50% have bought. We've got a problem out there. Why is there such a gap? First, why don't we have 100% of doctors using it? Well, we don't have that. But of the 50% that bought, only 10% are actually using the product in full technology. That's like going out and buying your new iPad and never figuring out how to turn it on, or you stop using it. Or I went out and bought an iPad right away, and my kids have been using it ever since I got it. I haven't even got a chance to get out and play with it because they found all kind of things to use with it. But my daughter, who is now just turned 16 Sunday, she started out in kindergarten with wireless laptops in public school. Now, I'm not talking a private school. This is just a public school. In kindergarten, they had wireless laptops, and the teacher did all the presentations using PowerPoint. Now that was, she's 16, so probably 10 years ago or so, I guess it was, or 11 years ago when she was in kindergarten. So the kids today are using the technology. But you get a doctor who's 60 or 55. I mean, 55-year-old doctor's still pretty young out there. And 50 and 60 seeming younger every day to me. But again, it's one of those things, they have not used this technology as much. They're not used to this. So again, we've got a gap out there. From a technology point of view, what would you think about if your technology, where you only had about 10 or 20% of everybody that bought it actually uses your technology? The rest says it's useless. I can't even use it. That's our problem in healthcare. People are spending money on technology and it's not meeting the needs of the end user. On the hospital side, we have an association called HIMSS, H-I-M-S-S, and that's when we have more initials. But basically, they've created something called the 7 stages. So every hospital in the United States has been kind of categorized in these 7 stages of technology. And again, you start out with a laboratory, which is all the testing down there, radiology and pharmacy, people that don't have a lot of systems. You start moving up. When you get into business intelligence, it's the level 6 and 7 organizations where I have enough data going into some kind of warehouse where I can actually analyze the data. And you look at 2011, we're talking less than 4% of hospitals today have enough technology built in where the business intelligence tools will really work for them. Yes, if I have a financial system and some basic clinical application, which is stage 3, and I got 40, almost 50% of hospitals are at that, I can do some analysis. I can do analysis on the financial side. I can do analysis on what the nurses are doing. But we don't have the physician interaction. Physician interaction does not get into until stage 6 and 7. We need the physicians involved because the nurses do not place orders in the hospitals. They actually do place the orders, but the doctor has to write the orders and the nurse puts it in. We got to move to the area where the doctors are placing orders themselves, and when I put something in, I put some conditions about the patient, their symptoms. We need some intelligence that comes in. We need Watson to come up and tell us exactly what things should we be looking at. It doesn't tell me what I have to do, but it gives me guidelines on what I need to think about. What are the new protocols that are out there? What's the best medicine, best practices? What are clinical alerts I need to know about at the point of care? We need it, but if you only got 4% of the hospitals at that point in time, having that capability, we got a long way to go. That's the exciting part about this. This is not an industry where everybody has technology. This is an industry where there's great opportunities to take what you have today and move it into the healthcare environment if you can basically communicate the same way. Too many times, again, I have technology speaking one language and the hospital people thinking something else. You got to find a way of blending those together. That's where I do a lot of my work. It's almost like a translator. I listen to the technology company, I listen to the hospital, I translate the two, and they go, oh, that's what they were talking about. So again, it's understanding how to speak to people is very important when it comes to this stuff because they like simple points. Show me how to do things. A lot of times I use the example of building a house. I have to have the foundation. I have to have the walls. I have to have the, you don't put the roof on until the foundation and the walls go up. There's certain things you have to do. In healthcare, we basically have a building block moving us up to where we need to be. And the goal is going to be where we have business intelligence tools that give the doctor, the clinicians, the nurses, physical therapists, whoever, information at the point of care. So when I see the patient, I've got the information in front of me. That's a level 7 in the hospital side. Here's our problem. This is a typical, the colors are not coming out very good, but this is the typical number of products we have in a hospital setting. Too many products. Why can't I buy a product, an EMR product or something like that? No, this is how many different products. In my hospitals, on average, we would have 89 different software products in a hospital. Radiology, pharmacy, laboratory, nursing documentation, materials management. In surgery, we would have materials management, anesthesiologists, and surgery just in one room. We have too many products out there. And there's so many vendors, there's 800 different vendors selling technology. We cannot go out and buy one product for a hospital setting. Now I can go to companies There's companies out there, Epic and Cerner, and Allscripts, Body Clips, where I can buy a suite of products, but I can't go to one vendor and buy one product to run everything. That's our challenge. It's a lot of different products. When it comes to business intelligence, I need to take all of the data from all these products and put it into a common data warehouse or something, or even better, that when I ask a question, it goes out and looks into 89 different products and finds the right answers for me, or brings up information. It's not simple because it's not one product, because we're very departmentalized in healthcare. What we really need to do, though, and this is where the industry is moving, is bringing everything together. Getting all the inpatient information, all the physician information, pharmaceutical, the retailing side of things, all the healthcare plan, bring all the data together. And I'm not saying into one big data warehouse, but connect everybody together. How do we connect all of these different stakeholders together in one system we can share data? We were talking last night about Denmark. The Scandinavian countries are way far ahead of where we are in healthcare when it comes to technology and when it comes to health. And Denmark's probably the best example out there. But again, it's more of a one-payer system. You go to Denmark, one doctor, you basically go to your one doctor and they take care of your health. No matter where you go, all that information's shared. Right now, we have silos of information everywhere. The goal is to bring all of this together where we can share the data, and technology gets us there. And now we call these health information exchanges, HIEs. How do we exchange data between all the care stakeholders that are out there? And really get pharmaceutical, health plans, physicians and hospitals, and everybody else connected together. And hospitals are one of the better groups to do this stuff, we have found, because hospitals are bigger. They got the big walls. They have bigger pockets. A lot of times they can do it. But these systems have to be physician-centric. It can't be built around a hospital, because as a physician, I may go to 6 different hospitals. I don't want to have to use 6 different systems. So the states are trying to bring stuff together, but we're moving so slow. But that means the opportunity's still there. Great opportunity for people to get into this market and make it work effectively today. Because bottom line, it should not take brain surgery to bring one community together under one simple physician-centric system. It should be very simple to do. We just got to find a way of doing it today. Go. The focus, though, about all this is the people. One of our challenges, as I mentioned, is we have EHR information overload. Too much data. In this case, too much paper to go through. But we got to find a way of figuring out how do we bring all that together. And the majority of the data, like in the iceberg, is underneath. It's not the stuff we see on top. It's everything underneath we got to look at. It's all the important stuff. It's everything about your social, family, and medical history. A lot of that drives things going forward. So we got to look at everything about the patient, not just the one lab result we got today. So most of the information is kind of buried in deep. We got to find a way of bringing all that out. And in our healthcare system, at least in the United States, everybody wants to stay somewhat separate. We are not one healthcare system. We are not one payer system. We got 1,000 different payers out there. But everybody wants to be separate and unique, but find a way of uniting it all together. Bringing everything together by connecting it all. And making sure we're all going in the same direction. We don't have to have one payer system. We don't have to have one healthcare system, as long as we're all going in the right direction, which has to be driving towards better health at a lower cost. Because everybody knows our cost is basically way out of line, but why is it out of line? Because we're going in different directions. Let's get everybody going in the same direction, but make it so you can stay individual. You don't have to be one group doing everything together. One of our problems today is that when you go to a doctor's office, the doctor collects information about you, and the primary care doctor. He says, I think you really need to go see this cardiologist. And they send you to a cardiologist. And that cardiologist is in a different practice. They don't have any of your data that was in your primary care. Now they may send a paper over or fax the information over. Now when you go to a doctor, your primary care doctors, they ask you all these questions. Then you go to the cardiologist, why are they asking the same questions again? Why aren't we sharing that information? Why can't I get whatever you entered in the first office, go to the next office? 83% of the data that's entered in by a specialist has been collected by somebody else before. Get that data to flow across. We can save a lot of time for doctors if I can just share the data. And we got to find a way of bringing all that together. All of your medications. If you're on certain medications, why doesn't all the doctors that you go to have access to your medication list, your laboratories, all the different tests you have? The big question ends up being is privacy. So how can I make it so I, as an individual, decide that I want to share my information with other doctors? Not any doctor, but only the doctors that I go to. And there's protocols we've set up for that. When I walk in and check into a doctor's office, I then say, yes, I agree that this doctor can see my clinical information. We can protect the data. We can make it that only your caregivers can see that information. We got to find a way of exchanging the data together. And we got to get that information timely to the actual caregiver. Don't analyze the data 90 days later, which is what most healthcare plans do. They look at 90 days worth of data and they analyze it. I need that data right now because I'm in front of the physician. Give me the information. I have my information to that doctor so they can make decisions. Give me all the information I need. And business intelligence tools can do that. They can go out and reach into all these different areas and bring the information to me at the point of care and give me knowledge about what's going on with me today as a patient compared to best practices that are out there. We need to bring all that together today. There's also something called DRT. Here we go back to 3 initials. Discrete Reportable Transcription. This is a word I coined about 2 years ago, with the Medical Transcription Association. The majority of data, remember I said, is paper-based? When you go to a hospital or a lot of doctors' offices, they actually go back and dictate a note. There are 500,000 transcriptionists who type up information about doctors' visits in the hospital setting or in the physician's office. You talk about a big business out there, 500,000 people typing up clinical notes. Well, when I get a clinical note, it's a piece of paper with words on a piece of paper. Why can't I get a computer system to read those words, pull out the important clinical information based on a coding methodology, which is called SNOMED, or medicine, we have 2 different methodologies, and bring that data out? That creates great value. Because now I go back to all that transcribed information and bring that in as discrete data. And that's what we're looking at doing. A lot of the organizations are kind of moving towards this. We have a wealth of information stuck in pieces of paper. Take that data out of that piece of paper, bring it into some kind of nice computer system, and have that data turn into information which creates knowledge. Most doctors have 10 or 15 years worth of information on paper. How do we get that in as data? When I bring that data in, now I can have my business intelligence tools analyze all this. I have orthopedic doctors that have thousands of charts and no data because everything's buried inside the paper. And you start looking at how much time it takes. One of the challenges we have with technology is that we're telling the doctors that used to think, now go back and you used to dictate your note or handwrite your note, now you got to enter it all in the computer. And you start looking at how much time it takes for doctors to enter information into the computer system on new patients and established patients. The EHR, you're talking basically it's 350 seconds, and we always use in seconds. If you're using electronic computer systems, it takes a lot longer to enter the data in than I did in the past. Doctor, we want you to use this computer system. It's going to take you 4 times longer to document everything. Isn't this great? That's the problem. The vendors say it saves all this time. Doctors, we automate everything. Your file clerk's not going to have to go look for a piece of paper anymore. Great. So I'm going to spend an extra 2 hours a day typing data in so I can save 3 hours of a file clerk's time? That's why healthcare has not moved forward. We're moving doctors to become data entry clerks and saving time for the clinician or the clerical people behind the scenes. But if we can move towards, why can't a doctor dictate their note and we let the computer pull all the data out? That's a lot quicker. It's a lot quicker than telling a doctor to go into a hospital system or to a physician office and enter all this data in. Because when I ask you how do you feel and you give me this little paragraph of how you feel, I got to go find those words in the computer system. It's easier for a doctor to listen. How do you feel? Tell me how you feel. And I interpret that and I dictate. So that's it's a transition from paper-based or dictation until we get to the full computer utilization. There's an incremental approach towards this. Now, how many computer software products are using this technology today in healthcare? 1. We've got a major gap. I've been talking about this for almost 2 years with the vendors like, oh, well, yeah, this is great technology, but we're basically selling our software based on getting rid of dictation. We don't want you to keep dictation. And what they're saying is, we want you to spend a lot more time entering data in my computer, making you work more harder instead of solving the problem. The problem is I need to get data in and I got to get it in quickly. And that's what a lot of the vendors are missing today, is how do I get it in quickly? There are ways of doing it from the technology. Now, some of you may have heard about this American Recovery and Reinvestment Act. There was a section in there that the government came up with, which is the High-Tech Act. And again, a lot of initials, that means it probably won't work. And that's one of our challenges today. They're putting a lot of money into this. They're putting $19.5 billion into IT technology for doctors and hospitals to embrace technology. That's a lot of money going on. This is over a 5-year period. This is the extra money they're giving doctors and hospitals to buy technology. And the goal is to get all doctors and hospitals, as much as we can, on technology by the year 2015. Well, that was the goal. You know, it probably won't get there, but we're trying to work towards that. And again, the money's going towards physicians and hospitals to embrace technology. And there's only 3 requirements. You had to use a certified product, you have to connect all the organizations together, and you got to report data back to the government. So pretty simple philosophy. The challenge is certified products, they set what's called MU, meaningful use. I call it minimal use, because it's really this, they set the standard so low that we went from about maybe 80 vendors in this market, now we have over 800 certified products. So you got a lot of products that won't even survive. These products, some of them are so bad, but they meet the government's minimum certification. They also don't require connectivity yet. So from the 3 requirements, no connectivity, no reporting of data yet. So we got a challenge. So again, even though the government's throwing a lot of money in it, they set the standard so low that we're really not getting the results that we wanted. Now in 2013, we're supposed to set the standards a little bit higher, but they decided let's move that off to 2014 now. So they keep pushing it out. The goal is the correct goal, to help us move towards technology. They're putting money into it. And now, again, when we have this kind of technology all together, the business intelligence tools really become very valuable. So by 2015, we need a lot of business intelligence tools, because the assumption is we're going to have everybody using technology. But that's a great assumption. Getting us there is a problem still. Doctors are getting $44,000 to $69,000, depending on which program they go under, to buy technology. Can you imagine, government handing you a check for $44,000 over 5 years to buy technology? You'd love it. And most doctors say, I want that money, sure. The challenge is they got to use the technology too. And that's one of the challenges, again, how do we get them to use that technology? One of the problems is, what do EHRs cost? This technology. One thing we don't go back at, government gives us this money, but what's it really costing us to do this? And you got to look at acquisition costs, implementation costs, the whole thing you have to do to actually get these systems up and running. Here's the problem. The red line is the money the government's giving us for this. And as the technology requirements get higher, the meaningful use requirements get higher, the costs go up. So today, I can basically, or 2008, when they set the dollar amount, that would get me a product that I need today. But when I add the business intelligence tools on, all the clinical decision support, all the knowledge that has to come together with it, that cost is going up. And the doctors are realizing over 5 years, a software product in their computer is going to cost them $90,000 over 5 years. I could go out and buy a lot of products a lot cheaper than that today. You look at the Microsoft suite of products, I'm not going to pay $90,000 to get that product up and running. Or I use Quicken, just for my own accounting system. There are a lot cheaper products. Why does a software product in a doctor's office cost $90,000 over 5 years? Because they're only selling a small volume. Most of the vendors are selling 100 to 200 licenses a year. The bigger vendors are selling about 1,000 licenses a year. But the largest organizations may sell 1,000 to 2,000 licenses. When there's 700,000 doctors out there, you would think there a lot more buying would be going on, but there's just too many vendors in this market today. What we really need in this industry is the trusted advisor, which could be somebody like you guys in the audience here, the software vendors, in this case the EHR vendors or hospital vendors or health plan, and then the practice or the hospital. We need a 3-way exchange. What we have is the vendor and we have the buyer. We need somebody else that can help bring all this together. Somebody that both organizations will trust. The interpreter, if you want to call it. But somebody who brings everything together. A lot of times it's on the consulting side. The consultants help bring a lot of this together. But we have found the end user and the vendor has a hard time in healthcare bringing it together. We need help on all this. And who do they trust? Most doctors trust, from guidance, other providers. So again, this is a big market for doctors to help other doctors. Clinicians, nurses, everybody to help other nurses. They look for help within their own organizations. They also look for, in this case, other companies that they already work with, billing companies, transcription companies. Healthcare people turn to people they trust today. What they don't trust is the software vendor. They don't trust the government. They don't trust these internet blogs out there today because, again, there's just so much. Every vendor tells me they're the #1 vendor in the industry. We're the best vendor out there. And then when I get done with them, they're kind of crawling away because I ask all these detailed questions. Most doctors, most hospitals don't know what questions to ask. They basically say, show me what your product does. And the vendor says, here's what our product does. The vendors don't show me what they don't do. Now, they've been trained, don't show these things, so we don't do this, don't cover those things. When you ask the right questions, the vendors look really bad. And most vendors hate me. Because I basically, think of me, has everybody seen American Idol? Remember Simon? I was Simon with a bad attitude. And my whole thing is, I want the winners. I want the best products that are out there for the doctors. Don't show me garbage. And all these products that are out there are really good to a certain point. But we found the software products, there's 42 gaps in software products that are leading to malpractice cases. If I buy an EMR, and I'm a doctor, I buy all this technology, I have a higher risk of malpractice because I bought technology. That is a problem. Now, none of it, oh, we don't have that kind of problem. And I get into the product, I show them where all their gaps are. They don't know it because no one's asking the right questions out there today. So again, one of the problems we run into too is decision making. Who makes the decision out there? In hospital settings and doctors, 55% of the time, they want to buy from the current vendor they have. If I happen to have this vendor today, vendor, do you have that product? Yes, we do. We want to buy from them, whether they have the product or not. The challenge is, I think, that a lot of people in this industry have newer products. They're the new innovative products that are really good. Very hard to get into healthcare because I want to buy from the people that are established. Give me 100 references. Well, I only got 10 clients. I don't have 100 references yet. They're very conservative in their decision making. I want to buy from somebody that's got a big name. And that really helps. So again, it's hard to get into this business sometimes. There's also all kind of surveys going on that help organizations understand what are the best vendors. And the problem is doctors and hospitals get confused with all these different surveys that are out there. And they all have different answers. Which are the best vendors? We need more market research on who are the best vendors. And the government certification, which is the top one, O&C, 499 vendors just on the ambulatory market. There's over 1,000 vendors totally now that have been certified by the government in different categories. Way too many vendors. Which is the best vendor? Who has the best product? We don't have that information. We got pieces of it, but you almost have to look at all these different surveys and roll them all together. Almost you need business intelligence to pull all this data together to come up who are the best products out there today. As I mentioned, one of the problems we have is the EHR rate of failure. Again, using technology. Just think of technology failure. Our philosophy is, doctor or hospital, you bought the software, you bought the technology, and it's been a year now. Are you able to use this technology for documenting your clinical notes on only 80% of your patients? And basically, 73% came back and said no. We've got a problem. We're selling technology that is not working in the doctor's offices or not working in the hospitals. And why is that? Are we asking the right questions? Do we have the right business intelligence tools to get the right information to figure out what's going on? Business intelligence tools work great. It's a great opportunity, but we got to have data coming in. That we can move from data to information to knowledge. If 73% of the data entry systems are not working, the business intelligence tools aren't going to work either because we don't have the right data. Doctors would rather use transcription or handwritten notes in the hospital and their doctor's office than technology today. Now, I'm not talking all doctors, but most doctors are in the industry today. They're looking at the numbers. Universities are a little bit different because again, we found a couple things. One is the universities, you either use the technology or you don't graduate. Or in the military setting, where the general tells the colonel to tell the major, you're going to use it or you're out. So those organizations work. The military works great, universities work great, because they have influence over the doctors. In the community, 87% of all doctors are independent from the hospital. They may work for the hospital, they're still independent CEOs of their own practice. They're very independent out there. So we got to find a way of bringing it all together, get everybody to work together. Take-home message with all of this is we have to find a way of creating a culture of accountability. That's one thing we really have a gap on today. How do we keep everybody accountable for the healthcare system as a whole? Why today is one doctor is responsible for this, another doctor is responsible for this, the health plans do something else. We're spending so much, over 30% of all health care is spent on handling the payment of the claim. There's no, over the Scandinavian countries, you're talking about 15% or 10%. We spend a lot of money on keeping track of what we did today so we can get paid for it. How do we bring all this together? But how do we create a culture of accountability for health? No one is accountable for your health. In theory, you're accountable for your own health, in theory. But one of our problems we have in the United States is patients don't take their own accountability for their own health. We have a big problem with diabetes. If you've been in any of the high schools or grade schools today, you see we got a major problem with obesity in the younger kids today. Everybody knows it's a problem. What are we doing about it as individuals? So we have to take, the culture of accountability has to start with us too. And again, we have to understand with the stakeholders, it's going to take a long time to get all the data together. We're not talking about having this done in the next 2 or 3 years, but we got to start now. Start building all this. The Watson project and everything else is great if we have the data coming in, but we got to get the data in structured format, or at least in a paragraph format where Watson can read everything and pull out the information it needs. We have to find a way of bringing it up. It's going to take a while to get there. We got to find a way of tracking the patients, the cost, and all the assets that we have. We've got a lot of assets out there, all the technology. The pharmaceutical side has a lot of great information. How do we bring all that together? And we got to find a way of incorporating the financial systems and the clinical systems together. Right now, those are separate systems. We got to bring them together. What is the cost for healthcare? We don't know. We know what we spent, but we don't know what the actual cost is. What is the cost for this kind of healthcare going on? But we need to involve physicians. So anybody that's out there in this industry, you need to get in physician-clinician involvement. It's great to get somebody from a university involved in these things because they have the great overall knowledge, but get practicing physicians. Too many times I've seen products that are built for a university setting or a Mayo Clinic or some organizations, everything's tied together, but will that fit in a 2-doctor physician practice? Over 60% of doctors are in practices less than 5-doctor practices. We got a small, whole little groups all over the place. What works for a big university may not work for a 5-doctor family practice or a 3-doctor orthopedic practice. Find a way of bringing it together. And finding a way, as a technology company, to get some immediate wins. Don't try to create something that's going to take care of the next 10, 15 years. Get some wins today. Find a couple clients and write good case studies about those. We don't have enough good case studies. Somebody bought a product and they like it. That's not a good case study. Quantify. Get third-party experts that can come in and quantify, these are the real benefits. We're looking for information. We're looking for case studies. Show me how this will work with quantified data. And don't tell me that your product is going to save time because somebody else said it would. Show me that your product actually saved time, saved money. So get it down to your solving problems within the business areas today. Here's my contact information. I think you already have my idea. We're going to make all these presentations available to everybody online, right?
That's right.
Okay. Questions? Yes.
Mark, a couple of questions. You're talking about the issues of getting doctors to come aboard on the technology. Mm-hmm. One of the things that the hospitals can do, because they can gain a lot from this, is to use the pressure that they have on doctors. I mean, doctors have admitting privileges or other privileges when they're hospitals. Why not use that to put pressure on doctors to adopt these new technologies?
So the question is, why? Hospitals are strong, and I came from the hospital side for my first 25 years. Why don't I put pressure on these doctors? Say, if you come to our hospital, you want to admit to our hospital, you have many privileges, you have to use this technology. We tried that during the 80s. And the doctor said, thank you, I have to use this technology, I'm going to take my patient someplace else. And that's what happened. CPOE, Computerized Physician Order Entry. 4 initials. Yeah, it doesn't work. We told the doctors, you come to our hospital, you have to go on the computer and enter all this data in. Doctors said, thank you, and they left. Because there's too many. I go to the other hospital and says, oh, you don't have to use the computer system, I'm going to go over there. So in theory, we do have the power to do that. If all the hospitals said, or if the government said you have to use technology or you get penalized, then we're going to move them along. Hospitals can do a lot of it, but a hospital can tell a doctor you got to put information into the hospital, But the hospital can't tell the doctor they got to put the information into their private office. And remember, about 80% of all visits are done in the private office. So we can't force them to do that. But forcing the doctors to do things, in universities it works, military it works, but in private community hospitals has not worked yet because the guy down the street says you don't have to do it. That's one of the challenges. Yes?
My primary care physician has been paper-free for the last 10 years.
Mm-hmm.
And this past September, when I was having my physical, I had a conversation with him about the same topic. And he told me that certainly his biggest problem is, you just touch a little bit on it, connectivity. Is the ability to get his information to other doctors and even to hospital. Now I went to my urologist and he had to fax his information
Correct.
to my urologist. So he's on board, but isn't the issue more about changing behavior as it relates to the physician and not, well, certainly technology and all the vendors, but I think the big part of it is behavior.
Well, yeah, so what he's talking about is, I've got my primary care doctor that's all fully automated, and then I have to go to a bunch of specialists who are not. How do I exchange data? Today it's done through a fax. We fax the data over. One of the challenges, we've not had a standard for information exchange. I've got 800 vendors selling products, and they're all in different structures, and I can't exchange data. Well, a couple of years ago, the government funded some organizations that came together, and we actually created an interoperability standard where we can exchange 70% of all the data following this interoperability standard. And so remember, going back to the stimulus money, remember that interoperability was required, and the government said everybody has to use this interoperability to exchange data, but not until 2014. So again, it's coming. We're gonna find a way, but right now, if your doctor is on one product, another doctor is on another product, they're both automated, those two products don't talk to each other today. But the standard's there for them to do it. So once we get the technology going, then I think the doctors will embrace it a lot more. Because remember, 83% of the data that the urologist needs was probably already corrected by your primary care doctor. Saves them a lot of time. Yes?
I have a question about like a validated processes, compliance, FDAs. How do you address that over here?
Yeah, there's a whole bunch of areas they have to look at, like FDA requirements. You know, in the hospital setting, if I have a computer within 6 foot of the patient's foot, it has to go through FDA approval and everything. But in the doctor's office, you don't have to have that. It's kind of interesting. What's the difference? But again, there's a lot of requirements around their compliance, and I just did a white paper on medical liability. Do EHRs increase medical liability? And we're finding out that they actually do. There's a lot of things. When do you have a software product that's increasing errors? That's a problem. Now, the software product does not increase errors, but it's the way the vendors are installing the product and the way the vendors are teaching doctors shortcuts. Doctor, I know my computer takes a lot of time for you to enter the data. Let me show you a shortcut that'll really fill out everything for you. So it basically says, when I come in and says, you know, I've got a little sore throat, the computer fills out that everything else is fine on me. It says my foot's fine, my ankle's fine, my leg's fine, my cardiovascular. Doctor didn't check any of that stuff. So the vendors are showing shortcuts that are actually creating more medical problems. You know, what software product out there is designed to cause harm to a patient? These products are actually moving towards it. So we got a lot of problem with compliance and medical liability when it comes to these software products, because again, people are not asking the right question. If I say I'm allergic to penicillin, I'm allergic to peanuts, I put that into my knowledge base about what I say, the nurse has to re-enter that into the allergy list. If they don't re-enter it, no alerts pop up. And the doctor says, well, it's in here, it says I'm allergic to penicillin, why don't I get an alert? Because it has to be in one specific field. So I have to re-enter the data. Why doesn't the data flow from my social, family, medical history into the allergy list, into my problem list? It doesn't automatically flow. That's a problem. And I'll be available afterwards in the networking session for asking questions too.
Hi, two quick questions.
He said only one. No.
Is the military, do you include the VA?
Yes.
And the second is, since the government's getting bashed for spending so much money on certain things, why can't somebody do a study on what the military is doing and use that
And they have.
as case study?
Yeah, the VA had one of the better systems that are out there. It really tracked a lot of things about older men. The VA did not have a system really good for females. Obviously, it had nothing for pediatrics. So they had some gaps out there. But the DoD system, Department of Defense, has another system that actually does a lot more on the female side. They're tracking the families more. So there's a way of bringing those two together. And that became a product that was offered to the United States, any physician, for free. The government actually said, we're going to take the VA product and offer it free to any doctor that wants to use it. And it really got down to is it didn't work for physicians, but a lot of vendors took that product and made it work. So a lot of the electronic medical records products that are out there, not a lot, but a few of them, are built on the VA system. So that product does exist out there. A free product that by the time the other software vendor added the additional technology onto it, basically costs as much as the regular products out there. Remember, in the VA, there's no formulary, there's no healthcare plan. Basically, the VA says, here's the meds you're going to use, here's the labs you're going to use, here's how we're paying for it, one way of doing everything. And in healthcare, I got to deal with 500 healthcare plans. They have 500 different protocols. They only had one. So it's a great foundation. We had to build on top of it, but it's a great foundation to start with, and they did.
I'd like to do is we'll walk the floor one more time with the bowl for the business cards. We'll ask a couple more questions to Mark, and then we'll have Mark pick the winner of the Kindle.
As you're walking back there, if you're in your Microsoft Word application and you type in EHR, it's going to change it to HER. So I see that all the time. So it doesn't, you almost have to teach that word. That EHR is actually a word. It's not spelling of her wrong.
A quick question for you, Mark. What's the role of commercial healthcare insurance industry in the whole push for EHR? They seem to be sitting on the sidelines. They're obviously one of the biggest beneficiaries of making all of this electronic.
Right. So about 6 years ago, I was working with Cigna, United, the Blues, and a couple other big health insurance companies to come up with one EHR that they want all of their doctors to use. It was like, this makes sense. We'll come up with one system and we'll provide it to all the doctors. And they got in that whole discussion of what were they going to provide, and then the whole committee ended up breaking up. Same old thing. There was not an incentive for Cigna, United, and the Blues to work together because they're all competing for the same patients later on. So it does make sense. Just like the government with Medicare. Why isn't the government just providing EHRs to every single doctor out there? Because 50% of all the cost of healthcare is being paid by Medicare, Medicaid, or the government, the VA. If we're already paying for it, why don't we just do it? So they are giving the money. They're just not saying which vendor. Now the government's saying as long as you have one of these certified vendors, it's good enough. But again, as I mentioned, they set the certification so low that I could take a Microsoft Word product with a template and make it work today. That will not work for the future, though.
Other than the subject matter specific to clinical informatics and healthcare, how does that really distinguish itself from what components of clinical informatics is composed in BI, data warehousing? Like, how do they really interrelate?
Well, if you think about, again, data warehousing and then BI stuff. So I look at my hospital, I got 89 different computer systems. How do I pull data out of all of those? Because I don't need every single piece of it. I have 1,000 data elements, and I want to pull 100 of those data elements and put it into a data warehouse. What we found in the past is that when I was in a hospital system and I wanted to search all of those different systems, everything slowed down to almost unusable. It slowed it down. So if I could pull those 100 data elements and put into a separate data warehouse, now I could do all my analysis on that without touching the infrastructure of this main system. You slow a system down for a doctor, they walk out. So you cannot touch the operational system. The warehouse can store that, and then have the business intelligence set on top of it that analyzes the thing. One of the challenges we have is coming up with the right question. What am I trying to solve? Give me all the patients that were a diabetic that has an A1C value greater than 7. I can do that today. But also has a lab result who also drinks 2 drinks a day that's wine related. When you start thinking about what questions you need to ask, that's where we run into the problem, is coming up with the right set of questions to help solve a healthcare issue. Why is obesity such a big problem in younger kids today is a good question. But what are the specific questions we need to ask to get to that answer? That's the hardest part today. Is it because of their lifestyle? Is it because of the food? Is it because of advertising from McDonald's? Is it because of we've gotten rid of PE and recess in school? Yes, it's all those combinations. But what one factor or how many things do we need to change to eliminate juvenile diabetes because of the overweight kids is a big issue. We got to work on that.
Let's do one more and then we'll turn it over to John.
There's been no mention of mobile and tablet technologies in this discussion. I would think that these would provide some amazing opportunities to streamline the process of professionals working with these systems and capturing information as well as delivering information. What is actually being done, and what challenges do you see?
Well, 90% of healthcare is delivered in a doctor's office or a hospital today. So I'm in front of a computer. I can use a notebook computer or a tablet. Think of it though as that when the doctor is in their home, they can go to a computer. Or the one I always example is we've got our sports doctors who go to the football games. And some kid gets hurt on the field or has some kind of reaction where they have a mobile device, can get instant access to what's going on today, plug it in, and get information from all the other data sources, bringing it all together. Or we did about 5 years ago with our paramedic program, where when the paramedics went out to the home or to an accident site, they had a handheld mobile device. They basically had a camera so we can video, so the emergency room doctors could see the patient. They entered information in, they did their vital signs. If there was a cut or something, they can view it. And the emergency room doctors and the paramedics were communicating effectively, providing much better health care to the patient. Instead of getting them stabilized, putting them in an ambulance and coming back 40 minutes to the hospital, they're able to start treating the patient right away. And probably the best example is still the military, where the corpsmen are going out in the field, somebody gets shot, and they have mobile devices for collecting a lot of this data. We got to keep that data secure. Somebody else also mentioned before is the privacy. I don't want my data over the cloud. I don't want my information floating around. We got to continue to keep ways of keeping that information confidential, but also I need that data to help provide much better health care. So mobile is the way we're going to be going. And right now, I'd say 80% of the requests I have for physicians is going to some kind of tablet form. I don't want to use a keyboard. I don't want to use a mouse. I really just have, right now I use a chart and a pen. What is a tablet? It's a chart and a pen. I can basically just do the same thing. I don't want to do this and a mouse and move around. And the worst part is when I'm doing this. Okay, what's wrong with you? Okay, let me do this. Now, what else is the problem? We see that a lot of times. I'm talking this way to the computer, and you're the patient. They're going, "Hello, I'm the patient. Look at me." A tablet, I'll guarantee you that people are like, "Oh, the tablets are too heavy." Tablets are a lot simpler and lighter than most of the charts that are out there today. We got charts this thick, and you're flipping through trying to find things. But we got to make it easier to find the data. Now, some of these EHR applications and hospital systems, 500 screens. Where before I could flip a page and I had everything right there that I needed. We got to get it to a simpler one summary page for the patient.
Please join me in thanking Mr. Mark Anderson for his contributions today. Thank you very much, Mark. Fantastic job.